Good morning, ladies and gentlemen. Good morning.
Good morning.
I hope you enjoy the selection of our location and you enjoyed the yesterday's location too. We are here in a beautiful city. Beautiful city of Ferrara, which is not very well known, but it's a jewel of the Italian Renaissance. And talking about jewels, we have a diamond of our profession today who will inaugurate and open our international forum, the Ultrashort Forum. I beg Professor Leonardo Trombelli to come on the stage.
I'm not quite sure that I am a diamond, but thank you anyway for this kind introduction. It's a real pleasure for me to welcome you here in Ferrara and to thank the organizing committee and Mauri and Professor Ivers to give me the opportunity to be here in this podium, which is a well-known podium for us that we live in Ferrara because it's part of the cultural activity of our city. And the reason, Mauro, why I'm proud to be here and to join you for this one-day meeting is twice. The first reason is that I'm positively surprised that you have selected this city for this important meeting. Surprised because, as you said, only few know that Ferrara is a UNESCO World Heritage and that it's one of the most beautiful Renaissance cities that we have, at least in the northeastern part of Italy. And only few know that Ferrara guests one of the oldest universities in Italy, and I'm really proud to welcome you also on behalf of the School of Medicine of the University of Ferrara, which I'm honored to chair for these 3 years. Ferrara University was founded back in 1391 by Pope Bonifacio VIII, and now it's a very important issue in our city. Think about that, basically in a city that counts 130,000 people, we are close to 20,000 students. So the university is not only important for us for the scientific and cultural activity, but also for financial reasons, as you may possibly understand. The second reason why I'm really happy to be here and introduced this morning is that in our research center in Ferrara, in the School of Dentistry, we have dedicated so much effort in order to develop procedures and technique that we call minimal invasive, and I'd rather call simplified technique. Simplified means that this procedure may be well accepted by the patient by reducing cost, disadvantages, drawbacks, limitation, but by optimizing what is the treatment outcome. We have developed surgical technique for periodontal regeneration, simplified surgical technique for sinus lifting, and so today we are very proud and very consistent in opening this meeting because talking by ultra-short implants is a consistent way to approach a delicate issue, which is the prosthetic rehabilitation supported by implant in a minimally invasive fashion. So again, since it's a meeting on ultra-short implant, I want to have an ultra-short introduction. And so again, I welcome all of you, ladies and gentlemen, my dear colleagues, to Ferrara, and wish you a very unpleasant stay here in our city.
Thanks a lot, Leonardo. You were very clear about the situation at the universities. A very fast announcement is maybe somebody's not listening to the translation. The translation for Italian is #1. You have to push the #1, and translation for English is for German is number 32. #1 Italian, number 32 is German. Nummer 1 ist auf Italienisch e numero 32 in tedesco. Va bene. Dunque, stiamo qui perché vogliamo introdurre ovviamente un concetto che è affiorito. Excuse me, I'm speaking in Italian, so I'm completely confused now with the translation. Okay, we're here to introduce you a concept which is the ultra short, and I don't know if it's so necessary for most of you to have an introduction on ultra short implants, but by the way, we have to respect certain aspects of consensus, international consensus, and so there were a decision made this year in February at the International Consensus Report on short, angled, and diameter reduced implants, where the implant sizes were decided or defined, and in this report you can see that ultra short is all implant length which is less than 6 millimeters. Now the short implants are between 8 and 6 millimeters, and so you will question yourself, what is this 1 millimeter of difference? What is it doing? Why we stop by 6 with the short, and why we stop with the ultra short? We start with the 5 millimeters with the ultra short. Stopping, I don't know, because maybe you stop in the future in 2 or 3 millimeters. This is the promise of Dr. Vincent Morgan. You promised it? Okay. But the important is now, what is it? Do we have enough literature? Do we have enough studies on ultra-short implants? Following our consensus conference, we don't have that. We still don't know the evidence of ultra-short implants worldwide. What happened? I'm talking about we because it's, you know, I don't have to hire a tier. It's almost all Bicon users. The Bicon implant is the one who has this short, ultra-short implants for different years, but there are now actually new ultra-short implant companies, and we have to look at what this means. We have to see if ultra-short is like ultra-short, if short is like short. There are big differences, and we have to respect these differences and look at the differences. And looking at the literature, like you see, we have not so many literature reviews, but it starts in 2005 with Professor Chong and his group from the Harvard University. 2005, then we have 2008, ultra-short sintered porous implant surface, and Professor D. Porter, which I can't see now. Professor D. Porter is should be here. Yes, we have a special guest, Professor Douglas D. Porter. Please an applause for him. And then we will see 2010, 2011, we have almost more and more. In the last years, we have different researches and follow-ups and long-term studies done on ultra-short implants. But it's not enough. And if you look at the market actually, that's the reality of the world market. I'm not talking about the local market, because local markets are not the reality of what happened worldwide. And so the world market looks like that. Companies, there's 5 companies actually, who shows up with implants, ultra-short implants, and ultra-short implant studies. Starting from Bicon 2002, like you see, always the pioneer in short and ultra-short implants, and so on. But if you look at the particular aspect of that 2 definitions, we will see that 2 of them are also for single crown restoration. The other 3 are for additional or auxiliary implant placement. That means they can't hold in the posterior a single crown, which reduces our therapy a lot. You can't place 2 implants only because they are ultra short and the company is telling you the ultra short has to be splinted. So, when and why using the ultra short? For sure, if you have this extreme atrophic bone, there is no other way. Maybe augmentation, but here you see a big and important group of researchers, guided by Esposito, is telling us, for many years now, this is one of many studies done, that vertical augmentation, we don't know where to go with them. What happened after 2, 3, 4, 5 years, and we talked yesterday in the pre-congress about that. Where to go? The other aspect is, like I told you before, is short like short, or ultra short is like ultra short? No. We have to look at the features, and we have to look at the design, like you know, of what happened. And here you see 2 different designs. Here you need always a bone grafting procedure, a GBR, to cover that implant, because there's nothing else to do, because the geometry of this implant doesn't allow you to bury completely the implant into the crest. And the crest is not always slight and smooth. Like you see here, the first millimeters are very thin, and then you can bury this implant design slightly under the crest, and then a looping shoulder is helping you and helping the situation to bury completely the implant in native bone. And here we have the aspect. You see that? That's the design we have actually at crest level. The neck of the implant becomes very important. As shorter you go, then finally you'll end up to have only a neck. If Dr. Morgan promises us 3 millimeter, it will be a neck implant. There is nothing else. And so, as shorter you go, as more important is what happened there at crest level. How much of the implant is engaged with the crest. And that makes the big difference between one and the other design if we go short or ultra short. Also if we go standard. But very important becomes this aspect if we go shorter. And here we have, also at the consensus, there's only 2 pages, but there's so many information in there. Yesterday we discussed half an hour about certain things, and we still continue to discuss about that. For example, we didn't touch yesterday in the pre-congress that phrase here, which says improvement in implant design and surface alone, is important. We have to change the idea of ultra-short, changing the mentality of geometry and design of the implant, otherwise it does not work. And we know that, and not only we, but also other companies. And which are the other features outside of the crest model is for sure the implant design for itself, a positional bone versus trabecular bone is completely different. The healing is something else. We're talking about, what can I say, Lamborghini versus Fiat. Almost like that. And so here we are. Okay? A positional bone is not giving us the same stability of an ultra-short implant as plateau-formed implant systems. And we will see, and we will have some of the lecturers talking about it. So we have cantilever-like bone formation inside the design, which makes the implant design possible to be shorter. We have the BIC, bone implant contact surface, and the augmentation of this surface is made by the healing chambers. And then we can have that aspects here, 9, 12, 15, 20 years, 1 to 5, 1 to 4. Implant crown or crown to implant ratio. The other aspect of the consensus conference was modification of the surgery. Many are forgetting that. That means it's not only the implant design, but we need also an instrument which allows that we can place the implants in very critical situations without hurting the patient. So, for example, if you have no bone in the posterior lower, we even don't do block anesthesia, all infiltration with this system, because it's possible, because we have that atraumatic drilling techniques, which are, you know, the ledge reamers are not cutting at the edge, and then I can do this, or can go closer. No irrigation, 50 RPM, and so on. Very important aspects to do even this kind of surgeries, getting to the shaft, connective shaft of the nerve, open the nerve. It's a lateral transportation? No, it's a compression towards the apical, nothing else. So we earn and we can gain, in certain cases, 1 to 1.5 millimeters, which is very important if you talk about ultra-short and atrophic bone situations. So here we are. That's what I told you before. If we don't have a sloping shoulder, it becomes a little bit more difficult, or really difficult, without bone grafting procedure to cover these very tiny implants and to embed them completely in native bone. Which is important. As less titanium surface I have, as more I have to be sure that all the implant is buried into native bone. And here we see, we go on the nerve. Like the Germans used to say, dem Patienten auf den Nerven gehen, and the patient is sui nervi. This is what we have here in aspect. Without block, it's possible. Traumatic, same thing in the upper. We can feel what we do. And it becomes very important. We are back in surgery, yeah, that's right. Not everybody can do it, maybe. We told also that you need training for it, but once you are trained, you can. And that's not a big problem. So, immediate loading. When we have to be careful with ultra short, we have to be careful if we talk about immediate load of single units, about immediate placement and type 4 bone voids. Pay attention, but this is normally for all kinds of treatments the same. And so here we see the comparison. What is this? This is an ultra short implant, because we're talking about zygomatic implants. They are engaged 5 millimeters into the zygomatic bone, and so once again we're talking about ultra short with a very long lever. And here we are, the opposite. What to do? Immediate function, or let's wait 3 months and then have something maybe less traumatic and more predictable. Here we are with an immediate load. Immediate loading doesn't mean that we are not going shorter. Like you see here, once again, you can go shorter. These are 8 millimeter implants, these are 15 to 13 millimeter implants. And so there are ways to do it, but you can't use ultra short for that kind of treatment until now. Same thing as immediate placement. We have to respect that thing. The size of the alveolar cavity. how big is the alveolar cavity? I take out a canine. The alveolar cavity is 15 millimeters long. The first engagement to the bone is very far away. Good, you can place an ultrashot, but it will be very deeply buried. So pay attention with that kind of treatments. Same thing, you plan to place an ultrashort, but then you have to place a longer implant because you get into a hole, the famous bone voids we're talking about very often, which is very important to have in mind if we are talking and we are working with atrophic bone situation. And it happens very often. Recently at the Midwestern University I was training with other colleagues, and they didn't believe about this bone voids. And I can tell you that of 10 cases we had 7 bone voids. And so if you don't know about it, maybe you don't look at it. But once you know that they exist, you have to pay attention. Mostly if you go ultra short, then you have to graft, like in this case, and maybe take a longer implant. So, what will expect you during the day? We have our 8 speakers here, and some of them will talk about about the general use on ultra short implants in every kind of situation. Use them 50 millimeters of bone height, 10, 12 millimeters. The width, it's not important. Use the ultra short implants, and they will show us how to use them in all conditions. The other group will show us the opposite. Extreme cases, extreme situations, like we talked before, ultra short, atrophic bone situations. There is no other way. And so the one is an option, maybe a treatment, future treatment planning, and there is no other than ultra short implant. Thanks a lot, and the next speaker